Okay, good afternoon, seniors and colleagues. Sorry about the technical issues. Today I'm going to talk on I'm going to talk about ANA. Solving the ANA and the autoantibodies puzzles. And I'd like to thank for this opportunity, because I've actually learned a lot in preparing this presentation. So hopefully you'll gain something from this presentation as well. Okay. So I'm sure all of us have come across this kind of lab result, and actually how do we interpret this? It seems very complicated, and with all these ANA patterns, titers, do they actually mean anything, or can I just ignore them? And why does the double-stranded DNA gives a value while the others only give me a positive and negative result? So does it matter? So I think it's actually quite an interesting topic to look back on. Actually, these results that I do get quite often. So there are actually a lot of myths. Does ANA positivity means autoimmune disease? But some people say they're too non-specific to be useful. So healthy individuals can also have positive ANA. So how do I actually interpret it? And do the ANA patterns actually matter? And is it just toys of scientists? Do I actually need to look into it? So hopefully by the end of the presentation, you'll have some ideas on these questions. Okay, so first, just want to go through a little bit of physiological background. So why do we get these autoantibodies? So what are they? So autoantibodies are abnormal antibodies produced by pathogenic B cells in response to self-antigens. And then an immune complex is formed from autoantibodies, the self-antigen, and also the other immune factors. Then this immune complex is then deposited in the tissues and causing dysfunction or destruction of multi-organs. So autoantibodies are often considered as an indicator of autoimmune diseases that are characterized by chronic, systemic, and excessive immune activation and inflammation, and can affect multi-system within the body. Okay, then I'll go through the technical background so we can understand more about the results of the test. So even as clinicians, we should be aware of the type of different assays used for ANA testing, and the advantages and also the disadvantages of using different assays. So actually, when we look at the ANA testing, the gold standard approach is to screening for ANAs in rheumatic diseases is detection via this indirect immunofluorescence method using the human epithelial type 2 cells, the HEP2 cells. And in the case of a positive ANA result, then we do follow-up testing to identify the specific autoantibodies present. So we do the solid phase immunoassays, we do immunoblotting to identify these specific autoantibodies. So for talking on indirect immunofluorescence, so first, the patient's serum will be diluted at different concentrations. I'm sure we're aware the 1 to 40 or 1 to 80, 1 to 160. Then the patient samples then would add to the plate and then incubated. And then, so any anti-nuclear antibodies from the patient would then bind to the autoantibodies. And then we subsequently add another sort of detection antibody, which will then be visualized using the microscope. Okay, so then, as I mentioned, so if the ANA screen is positive, then you do the ANA titration. So if it's so you do it from 1 to 40, 1 to 80, 1 to 160, 1 to 640, etc. And the test report would then give you this antibody titer and also an antibody staining pattern. This is just a new concept. Nowadays, as I just mentioned, this is the standard or the approach to test for ANA is by the Hep2-IIF method. But actually, this method does not only reveal reactivity to the nuclear antigens, but also to the cytoplasmic and also the mitotic antigens. So actually, the anti-nuclear antibodies, so the nomenclature is not quite right. So this new term, anti-cell or anti-cellular antibodies, might be preferable to the ANA, but this changing the traditional nomenclature is likely to be difficult. So even though the test that we do actually detect all these antigens, the nuclear antigens and also cytoplasmic and mitotic antigens, but still we refer to as ANA. So now I'm going to talk about why it's important to look at both the titer and also the fluorescence pattern. So for the ANA titer, we do know the we do know the cutoff value, but it has been it's been changing. So previously, the international recommendations define the cutoff value as the titer that corresponds to the 95th percentile of healthy individuals. So it counts as positive if it's equal or greater than 1 to 160. Okay. But then this new classification for SLE came out in 2019, the EULAR and the ACR SLE classification criteria, where they include a entry criterion. And the entry criterion is a titer of 1 to 80. And they chose this criterion because it has a high sensitivity, but also a relatively low specificity. It's important to look at the titer instead of looking at a single cutoff value, whether it's positive or is negative. Actually, the likelihood of the disease increases with the increasing antibody level. Okay, sorry about the resolution, but I'm sure you can still see. So basically, if we use a lower cutoff point 1 to 40, then you get a higher sensitivity, but obviously you also get a high false positive results, as in you get healthy individuals do have ANA as well. So the increase, the likelihood of the disease increases with the increasing antibody level titer. So this is important instead of just looking at a cutoff value. Okay, so another thing would be the staining pattern. So it provides useful information in the disease diagnosis because different patterns mean different things. And the classical nuclear patterns are speckled, homogeneous, nucleolar, and centromere. So, with the presence of anti-double-stranded DNA antibodies, it would give a sort of homogeneous picture. And then with sort of anti-SSA, the anti-Rho antibodies, then you would get this dense, fine, speckled pattern. So actually from the pattern, you might be able to tell which autoantibodies are actually present. But obviously in real life, it's not that straightforward. Usually we get multiple ANAs and then we get a sort of a mixed pattern, and it's difficult to interpret them. So that's on the initial ANA screening. So if it comes back positive, then as I mentioned, then you should do some follow-up testing to see actually which autoantibodies are present. So with the anti-double-stranded DNA, you can see we use, our lab uses ELISA as the method to give the sort of quantitative result. And then with anti-ENA, then they use sort of immunoblotting. So I'll go through these methods just briefly. So with the anti-double-stranded DNA, for example, the ELISA method, so is a solid in the solid phase assays, a solid phase surface would be used and is coated with a mixture of autoantigens. And then the patient sample, if there's any autoantibodies presence from the patient sample, then that would be bound, that would attach to the autoantigens, and then we add in the detection antibody. And then this would give a readout of the ANA, the concentration via the ELISA, which is the enzyme-linked immunosorbent assays. And then it will give us a readout eventually. So this method is fast. It can test for many patients at the same time and has a quantitative results. But we need to bear in mind that the performance and characteristics of these screening SPAs are actually assay dependent and also disease dependent. So it depends on what assay you're using and also which disease you're actually looking at, and they would give different sensitivities and different specificities. And none of the assays is overall superior to other assays or to the HAP2 IIF. So each of them has a different strengths. Then with the immunoblotting, in the multiplex immunoassay, the autoantigens are usually immobilized as a line or dot on a nitrocellulose membrane, and then the autoantibodies would bound to the nitrocellulose membrane, and then they would be detected again with the detection antibody, the anti-immunoglobulin antibodies. And then again, you use different methods to look at to detect them. So then it's this method again is fast and it can test for multiple autoantibodies at once, but it might give false negative values. And traditionally, in our lab supports limited ENA immunoblotting, and you can see it tests for the 6 anti-ENA antibodies. And traditionally, anti-double-stranded DNA antibodies would be the one being reported quantitatively, and actually the others with the immunoblotting method, then a qualitative, whether of a yes or no result will only be given by this ENA immunoblotting method. But this is the tradition way. Actually, from the scientific perspective, now we're trying to look at these even the anti-ENA in a quantitative ways, but it's just not routinely done in the clinical laboratory yet. But I'll go on and talk to this a bit more later on in my slides and see why this is important. Okay, so actually all this testing are still not standardized yet, and is actually and this is actually quite important. So even saying the golden method, the HEP2-IIF that is used for an ANA screening, there's still lots of variations in methodology of sort of which substrate used, which fixative and the optic used. And then looking at the pattern, there's subjective evaluation of the positivity, and even there's automated, like computerized programming could be done, and still it needs to be validated by visual evaluation. So there's actually a great variability even on just on the testing, and so once you test it negative, if you use another method, then it might give you another result, and also different results might come back across different laboratories. So there's great variations in these in the methodology. So just to be aware of that. Okay, then then I'll talk on how to approach when actually when you get the lab result when there's a ANA positivity. So what can actually cause a positive ANA? Of course, we've talked on the possibility of autoimmune diseases, and we may know sometimes actually even pre-autoimmunity, anti-SSA, anti-Rho it can be present even before the stage of disease when full-blown signs and symptoms have yet to be developed. And for infections, for example, if you suffer from infections like mononucleosis, then your immune system is constantly activated by the virus, and this could also cause the formation of autoantibodies like the ANA. So this might cause a transient positivity in the ANA. And there are also medications that could cause positive ANAs, and some can even cause lupus. And for example, the anti-TB drug, the isoniazid, or even the anti-TNF. And again, as I already mentioned, so healthy individuals, they can actually have a positive ANA as well. And this might be why. So they find that this anti-DFS70 antibodies, they actually give a nuclear dense fine speckle pattern, and it can also occur at high titers for samples from healthy individuals, and it happens they're present in 1 to 8% of healthy individuals, and this might explain why sometimes a high titer ANA test in some individuals who actually don't have any evidence of an ANA-associated rheumatic disease. So another point that I would like to highlight is also that what if that I mentioned that this new criteria, the 2019, I blocked the title. So the 2019 EULAR ACR classification criteria for SLE. So this is the entry criterion where you actually have to have a titer of 1 to 80 with the ANA to actually as an entry criterion to be classified as SLE. So the question would be, does ANA negative SLE exist? So the answer is yes. Even we have changed the, we have a different concept of this ANA on this anti-cellular antibody. So this author had examined the prevalence of the IIF anti-cellular antibody staining on the SLIC inception cohort. So the SLIC would be the old classification criteria back in from 2012. So they used the SLE cohort from the SLIC classification criteria, and over 1,000 patients were included in this study. And they still found actually 6.2% of them were anti-cellular antibody negative. So this reminds us that even there are actually quite a substantial prevalence of SLE patients who have ANA negative result. Okay. Right. Okay. So moving on. So now I would like to talk on different types of ANAs. So actually, I'm going to cover the major two types. So one would be the types that bind to the nucleosomes, which is the form in which DNA is found in the cell nucleus. So the anti-DNA, I mean, we most recognized would be the double-stranded DNA. So we know the anti-double-stranded DNA are highly specific for the classification for SLE, and it is also associated with disease activity. Okay, and the other group would be the RBPs, the RNA binding proteins. So these antibodies, they are also termed as anti-ENA antibodies. So they recognize the RNA protein complexes, and then they are termed as anti-ENA antibodies as well, because because of the use of the extractable nuclear antigen, and the ENA is actually tissue extracts that contains nuclear material along with other cellular components. And the examples would be the anti-Smith and the anti-RNA antibodies, and also the anti-SSA, the anti-Rho, and the anti-SSB, the anti-LA antibodies that we know. So why do I want to bring up these two important groups of ANA antibodies? Because they have very different. They might be very different in terms of the fundamental different B cell responses. So with the anti-DNA antibodies, they come from the naive B cells that transition to plasmablast, which require proliferation for their differentiation or maintenance. And these antibodies can potentially and these antibodies varies greatly, and we use it as disease monitoring, and we know that it could, and we know that after at diagnosis, it could be very high, for example, in lupus nephritis, and then if and after treatment, they can disappear. And then if a patient has flare, then these anti-DNA antibodies can return. So it actually varies greatly. And while the other group, the anti-RBP antibodies, the anti-ENA antibodies, actually, they are consistent over time. They are different. They are produced by these long-lived plasma cells in the bone marrow that are no longer proliferating and are therefore less susceptible to the immunosuppressive therapy. So these are the two main differences, and this might potentially explain why actually the anti-DNA antibodies could vary greatly, and while the anti-RBP antibodies, the anti-ENA antibodies are actually more sort of persistent in the disease course. Just adding to that, so actually on testing, as I mentioned, so the anti-DNA double-stranded DNA antibodies actually is a marker of disease activity. But then whether repeat testing on the anti-RBP has any point in it. So it had been deemed unnecessary in routine care after the sort of diagnosis made, and is not commonly performed again, the anti-ENA antibodies. But actually nowadays, we actually think that periodic serological retesting might be justified, especially at the time of a flare. Then it can help us to understand more about the disease mechanisms and the treatment response, etc. So actually now, actually retesting on these anti-ENAs might actually be useful. And as I mentioned, that we're actually, from the scientific perspective, we're actually also looking at whether the quantification of these anti-ENA antibodies are actually useful as well. But obviously, as we all know, the anti-double-stranded DNA antibodies is the one that we now use as a marker of disease activity. Okay, so and another point would be the association with all these different types of autoantibodies. So the anti-double-stranded DNA antibodies is associated with lupus nephritis, and then we know the anti-Ro antibodies is associated with subacute cutaneous lupus, and the anti-ribosomal P is associated with SLE patients with CNS manifestations. But actually, there are still quite a lot that we don't know about these autoantibodies, perhaps as to which specific autoantibodies play in the role in specific clinical manifestation or even overall disease activities. There is still a lot that we don't know about these specific autoantibodies. So another point to make, why is this seropositive and seronegative status of this SLE in SLE patients is actually important, because it alters our treatment. So this is the new biologic that has been approved for as SLE treatment, the belimumab, and this is and in the BLISS trials, so actually they show that the belimumab actually has greater improvement in patients, in the subgroup patients with actually renal involvement, and also with low C3, C4 levels, and also anti-double-stranded DNA positivity. And so that's why it's recommended now that belimumab is used in the seropositive SLE patients. Okay, so I probably don't have time to cover the roles of ANAs in other diseases, but obviously we use ANA to predict uveitis risk in JIA patients, and we know that the anti-SSA, anti-SSB antibodies are important in sort of neonatal lupus, and then sometimes there's when we do ANA testing in JDM, then we got some positive results as well, but obviously it's not there all the time because we use different methods to detect the myositis antibodies. So in summary, so the first point, again, to address the new term to use, the anti-cell or anti-cellular antibodies, by the gold standard, by the ANA testing by the HAP2 IIF method, that it actually includes the reactivity not just to the nuclear antigens, but also the cytoplasmic and the mitotic antigens. And the actually the two major groups, the anti-DNA and the anti-RBP antibodies, they show distinct patterns of expression that relate to their origin from different B cell populations. And then the amount of ANAs in SLE patients can change over time as a result of either natural history of the disease or the effects of immunosuppressive agents. So actually, it's worth rescreening the ANA levels and rechecking them. So they might be negative, but if you have high suspicion in a patient, you're worried about I don't know, SLE or something, then it's worth rescreening the ANA levels because it changes, and this could provide important information about disease mechanisms and disease status as well. Thank you.
Well,